So there are fascinating things happening in the transplant-ineligible myeloma era. And for a long time, it's been known that elderly patients are doing the worst in terms of outcome, survival, because most of the patients are dying in the first months following diagnosis. And through the years, we have come to the step now using triplets instead of the doublets. And the triplets either is a PI plus an IMiD combination or a monoclonal antibody, anti-CD30 plus an IMiD. So these studies, these protocols gave a median progression-free survival of 3 to 5 years. So this was a major step forward. But nowadays, starting with the recent ASH meeting and more recently during the ASCO meeting, there has been new data presented. And these data belong to, for instance, for the ASH meeting, it was mainly for the intermediate fit patients, more intensive approaches with the quadruplet containing carfilzomib instead of proteasome, so very, very intensive approaches. And during the last ASCO meeting, there were 2 presentations and going to the plenary session. And these were keeping the experimental arm, ISA-VRD, comparing versus VRD in the IMROZ study and comparing against ISA-RD in the benefit study. These protocols are completely different, even though they are called ISA-VRD. The details are behind, it's written behind the scenes that you have to look carefully into the protocol designs. But however, at the end of the day, there's a very deep response attained, and with like 5 years follow-up with the IMROZ study, now it's possible to reach very high CR rates and also more than 50% MRD negativity, which is sustained MRD negativity. So this is a major progress. And then now the question is, which patients are candidates for a quadruplet, namely, let's say, ISA-VRD, versus those who are more convenient to take the VRD type, the triplet regimen, or the KRD regimen. The ASH data shows that KRD, from the GEMFIT study, KRD is good for patients who are less fit, compared to more fit patients favoring from the DARA-KRD regimen. The question today is to judge at diagnosis which patients are eligible for a more intensive type of regimen. Although they are not eligible for transplant, the more treatment we give them, the better efficacy, but we have to tailor against the toxicity to prevent them from discontinuation.